All right, everybody, welcome to Pharmacology Chapter 1. I'm going to share my screen and pull up the PowerPoint so that we can all see it and follow right along. So this is out of your pharmacology book, Introduction to Clinical Pharmacology, Chapter 1. This is the basic general principles of pharmacology. So what is pharm? It's the study of drugs and what they do to living organisms, their actions. And remember, everything that has to do with pharmacology must always insert the word safe or safely, okay? So having a knowledge of these basic principles makes sure that you have a safe administration of medication to your patients, okay? And safety is the word. When we look at medications, we have drug names and then we have categories or classifications, okay? So the categories, chemical, generic, and then the trade or brand name. So always use the generic name. You may come across a med and say, oh, I know it by the trade name, but you got to know the generic name. That is the name that you will be seeing on tests, on your predictor, and on the boards, okay? All medications that are pharmacological agents have to get approval from the FDA. And so the FDA gives categories to drugs. They're either prescription drugs, non-prescription drugs, and that doesn't include herbals and supplements, by the way, it does not. So prescription drugs, non-prescription, and then controlled substances, you know, the fun ones. So when drugs get into the human body, they have an action and they can act in different kinds of ways. Just understand that the root of the drug has a lot to do with how quickly the drug acts and how it has to get broken down in the body, right? So with oral drugs, you have 3 phases: the pharmaceutic phase, don't worry about that; the pharmacokinetic phase, which is absorption, distribution, metabolism, and excretion. We are going to talk about that. So the pharmaceutic phase, remember, and this is highlighted, so this is what you need to know. A liquid or parenteral drug, okay? It's already dissolved, it's liquid. So those are the ones that get absorbed the quickest. Solid drugs like tablets or capsules, they have to be swallowed. They have to go down in the digestive tract to the stomach and the intestines and dissolve there to be absorbed. Slower. So PO medications, slower. And then there are things like extended release, long acting, and enteric coated tablets. So enteric coated tablets, why are they coated? They're meant to not break down in the stomach. That coating protects them from the acid in the stomach. So they stay whole in the stomach. They get broken down in the small intestine. So they should never be broken or crushed, okay? Okay, the pharmacokinetic phases, okay? Absorption, distribution, metabolism, and excretion. Let's talk about what you need to know. Absorption. So that's how quickly, how much time has to elapse between when I give you the drug and it starts to do its thing, right? You see, I put 3 stars in front of this. Factors influencing the rate of absorption. The route of administration is a factor that, you know, affects how quickly or slowly meds get absorbed. PO meds are slower. The fastest way to get a medication in someone and get it to act, IV. Subcutaneous and IM, they're kind of in the middle between the two. They're not as fast as IV, but they're not as slow as oral meds, okay? Metabolism and excretion. So excretion, how does what's left of the drug get eliminated out of the body, okay? There's 2 ways. It's either the kidneys or the liver. They are the 2 organs, primary organs for excreting drugs. If a patient has either kidney or liver disease, oftentimes their dosages have to be reduced, and we really have to watch their lab values for their kidney function, renal function. Make sure you know renal means kidney. And their liver function, hepatic function. Hepatic means liver. And then older folks. As we get older, well, not me, but other people, as they get older, things slow down. So kidney function, liver function, slower metabolic rate, everything slows down a little bit. So older folks have to really be watched carefully because they're the ones that are at the highest risk for not being able to metabolize and excrete drugs, get them out of their system. Don't worry about onset and duration. No one's going to ask you about that. Various drug reactions. This is important. You need to know what all of these are, the definitions. First, we have an allergic drug reaction. What is an allergy? Allergy is defined as a hypersensitivity response to an ordinarily benign substance. In other words, I have hay fever. Pollen is benign, and the word benign means not harmful. Pollen is benign, but because I have hay fever, I have a hypersensitivity reaction. So in the spring, you'll see runny, watery eyes, runny nose, those kinds of things from the pollen. It's an allergic response. With medications, a drug can produce an allergic response in a human. We don't know why, but usually the first exposure, so let's use penicillin as an example. Patient has an infection that's bacterial. Penicillin is what we want to give them. We give them penicillin. The first exposure to the drug, the first time they take that drug, usually will give someone a mild response, okay? Mild response. And that's usually pruritus, which is itchiness, and urticaria, which are hives, okay? So now we know, oh, she's allergic to penicillin. We won't give her that again because any subsequent exposure can cause what's called anaphylaxis or anaphylactic shock, and that is deadly. That will kill you, okay? So remember, first exposure to a drug, usually a mild response. Make sure you understand itchiness is pruritus, urticaria is hives, but know that any subsequent exposure, if I give that same person penicillin again, their throat may close on them. They may go into anaphylaxis. Then we have drug idiosyncrasy. That means the drug is doing the opposite of what it's supposed to. We have drug tolerance. That means over time with constant use, you get used to a drug and you need a higher dosage, or maybe you need a different drug at some point. Cumulative drug effect is before the patient's previous dose is excreted, we give them another dose, and that can be toxic. Then we have toxic reactions, which is a cumulative buildup of a drug in the patient's blood that can cause harmful or even sometimes deadly reactions, okay? So I'm going to expand on all of these a little bit. Allergic reactions. What happens is, and we don't know why, for some people, their body views that medication as an antigen, something dangerous like a virus or a bacteria. And so their body responds with itching, skin rashes, hives, wheezing, which is a musical sound, cyanosis, a blue tinge, to severe sudden loss of consciousness, swelling of the eyes, lips, or tongue, which is angioedema. And the tongue gets so swollen that anything here will swell up, and they won't be able to breathe, which they'll go into anaphylactic shock and they'll die. Okay, so that's allergic drug reactions. Idiosyncratic reaction. It's an unusual, abnormal, sometimes extreme opposite reaction to a drug. I'll give you an example. The patient's anxious. I give them a Xanax. Instead of chilling them out, which is what alprazolam, Xanax, is supposed to do, they get more excited and agitated. Idiopathic, idiosyncratic reaction. And idiopathic, the word idiopathic means, it means I don't know why. So why did that patient have that idiosyncratic reaction? I don't know. For some reason, that drug for that person did the opposite of what it was supposed to do. Then we have tolerance, right? So the drug's not working anymore. The best example, sleeping pills. I've been taking a sleeping pill every night for the past 6 months and it worked and now it's not working. Well, you've developed a tolerance. So now we may need to increase your dose or we might have to give you a different drug. Tolerance. The body has gotten used to the drug and it's not producing the desired effect anymore. Cumulative. Usually you'll see this in patients with liver and kidney disease and older folks too. Body can't metabolize and excrete the first dose of a drug before the next dose is given. And so we identify these things before we administer drugs. We look at labs. What is the BUN in creatinine? And that talks to us about their kidney function. What is AST, ALT, bilirubin? That talks to us about liver function. If we see there's a problem, then dosages have to be modified, right, to accommodate that person. And then toxicity or toxic drug reactions. And you'll see that there's a list of medications, and I'm going to put this up on Teams, that we have to measure serum levels. In other words, how much drug is in the patient's bloodstream. And there are levels that are therapeutic. Anything higher than that is considered toxicity. And if a patient becomes toxic, well, they're going to need an antidote. And so those drugs, we will talk about them as we move through the different medications, but you need to know vancomycin, theophylline, digoxin, phenytoin, carbamazepine, and warfarin, okay? And those, and heparin and mag sulfate. Those drugs all have therapeutic levels and they all have antidotes, okay? So we'll talk about that later on. Then we have additive, synergistic, and antagonistic. So let me try to break this down. Additive, it's right there in the name. That's the way to remember it. Additive means that if I give you this drug and I give you this drug, the combined effect of both of those drugs is still equal to if I gave each of them alone, right? So I give you a blood pressure pill, hydrochlorothiazide, which is a thiazide diuretic, and I give you an ACE inhibitor, lisinopril. The ACE inhibitor is going to do its thing, and the hydrochlorothiazide will do its thing. But combined, they don't do any more than what they normally would do alone. Okay, that's the additive drug reaction. It's the no harm. Synergistic drug reaction. 1 + 1 = 5. That means that these drugs, when given together, they interact with each other and they produce a sum, a total greater than each of their separate actions. Example, Xanax, alprazolam. That's a benzodiazepine chill pill. Give you an alprazolam and I give you a Lortab, right? Which is an opioid. Each of them alone does their thing, but if they're taken together, 1 + 1 doesn't equal 2. 1 + 1 = 5. Each of them will kind of exacerbate the other, and the patient will be what we like to call in the business AFU, or snowed, right? They'll be very, very sedated, okay? Which they would not have been had those drugs not been given together. So a synergistic drug reaction is 1 + 1 = 5. And then we have antagonistic drug reactions. Drugs are either agonists or antagonists. Just remember, an antagonist, you're antagonizing me. You're stopping me from doing what I want to do. Stop it. An antagonistic reaction is when one drug blocks the effect of another. Best example, opioids and Narcan, naloxone. If a patient should overdose on opioids, whether it's heroin, pills, doesn't matter, causes respiratory depression and death. If I give them Narcan, naloxone, it blocks the effects of the opioids and they won't die. Okay? It's pretty easy to understand. When we talk about drugs, there are reactions and interactions even with food, right? There are some drugs that must be taken on an empty stomach, antacids, right? There are some drugs that irritate the stomach. They can cause nausea, vomiting, epigastric distress. Epigastric is here, stomach, okay? They got a stomach ache. And these meds should be given with food. Example, NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, meloxicam, celecoxib, naproxen sodium, right? Those are all NSAIDs. They need to be given with food or even milk. And then there are some where certain foods combine with certain drugs and either do a good thing or do a bad thing. Example, if you have a patient that's taking an iron supplement, well, ferrous sulfate is what it's called, then you want them to take that iron supplement with something that contains vitamin C. Because vitamin C, which is found in like orange juice and grapefruit juice, citrus juices, right? Vitamin C actually helps the iron get absorbed in the body. But you never, no, give iron, ferrous sulfate with dairy products like milk. That'll block the absorption of the iron. Okay, so you got drugs that are taken on an empty stomach, some need food, and some certain foods. You will find that grapefruit juice is very, very bad for many drugs. There are lots of medications, pharmaceuticals, that do not play nicely with grapefruit juice. And we'll go over them as we get to them. Okay. So there's a little question here in the PowerPoint. Is the following statement true or false? Age is a factor that influences drug response. Yeah. Know this. Know that age, weight, gender, any other diseases the patient has, routes of administration, these are all factors that influence how the patient responds to a drug. Okay, right there. And then nursing implications. In other words, what is your job? Your job is to not kill the patient. That's the doctor's job. Your job is to make sure that you don't ever give a drug that someone else poured. You're at work. Oh man, I'm so busy. I'm so busy. I just poured this cup of meds for Mrs. Jones. Do me a favor, man. Will you give that to her? I got to call my son's school. Nope. Don't do it. Okay. You can go to the MAR and you can pull the meds, but you never give meds that someone else pulled. You always look meds up. Where? The nursing drug guide. Could be Davis. It could be there are others. Lippincott makes one. Doesn't matter. But you never give a medication without looking it up first. Your job is to make sure that the patient's response to the drug is safe and therapeutic. If I'm giving you a medication to make you stop vomiting, did you stop vomiting? It's on to Cetron. Right? You have to be able to report on your patient's response. You have to be able to use good, sound clinical judgment. Okay. So all of these things are your job as the nurse. No one is going to ask you about mechanism of action of drugs. You're not going to be pharmacists or chemists. The questions you're going to get asked are going to be about what is the drug used for? What are the side effects? What are the adverse effects? Do they need blood drawn? If they do, what's the therapeutic level? Can they become toxic? If they can, what's the antidote? What are drug-drug interactions? What shouldn't you give with this drug? How about drug-food interactions? Those are the kinds of questions you're going to get asked. Okay. And then last but not least, herbals, herbal therapy and dietary supplements. Just remember this. Herbals and over-the-counter supplements, like vitamins, they are not monitored by the FDA. So if someone says to me, oh, take turmeric. Turmeric, it's great for inflammation. What kind of inflammation? Just general. So I buy into it and I go buy myself turmeric and it says turmeric, 100 milligrams per capsule. Could be 100 milligrams, could be 1 milligram, could be 1,000 milligrams. No one is watching, right? There's no oversight with herbals. And just because something's natural doesn't mean it's safe. Cocaine, right? Natural, okay? Remember, herbals, almost every herbal out there somehow interacts with pharmaceuticals, with prescription meds. And there's a list of herbals that you need to know. St. John's wort, echinacea, ginger, ginseng, ginkgo biloba, feverfew. The list goes on, but it's a very specific list, and we'll get into that soon. But just know that supplements, over-the-counters, herbals, those kinds of things, and that doesn't count non-prescription drugs like Tylenol, acetaminophen, okay? Those are non-prescriptions. Supplements and herbals are not non-prescriptions. They're just over-the-counter drugs, right? And they're not necessarily safe. Patients should always tell you every single thing that they are taking, right down to a vitamin, an herb, everything, because all things can interact with one another. And that's the end of the first lecture. So I hope you enjoyed it. I am going to stop my recording now